Opioid Agonist Treatment, or OAT for short, can be a life-changing treatment for opioid dependence. At the Medically Supervised Injecting Room, a service run by North Richmond Community Health, more than 400 people have successfully commenced the treatment with remarkable results. My name's Mia, and today I'm joined by a special co-host, Dr Nico Clark, Medical Director of the MSIR. We're going to discuss OAT, how it works, and how it can change the lives of those who receive it. To guide us through this, we'll interview one of the doctors working at the OAT clinic at the MSIR, Dr Tony Weeks, along with one of the MSIR clients, Peter, who's generously offered to share his story with us and offered for us to refer to him by his first name on the podcast. This episode will have a special focus on Long Acting Injectable Buprenorphine, which is a bit of a mouthful to say sometimes. It's referred to as LAIB on the podcast. Peter refers to it as Buvidal, which is one of the brand names of this treatment. Before we go any further, I should mention that this episode will discuss injecting drug use in detail, which may affect some listeners. Support's available through Direct Line, the Alcohol and Drug Counselling Information and Referral Service. The phone number is 1-800-888-236. All right, let's get to it. My co-host today is Dr Nico Clark. He's the Medical Director of the MSIR, and he's also an addiction medicine doctor with 25 years experience of providing opioid pharmacotherapy treatment. And I just want to acknowledge how pleased I am that you're my co-host, because it's really good to have someone who's an expert in this field. I often say to people, it's like a journey being a layperson who doesn't know a whole lot about the subject, and I'm learning as I go along. So I'm happy that you're here to add a lot more depth to the conversation with Dr. Tony Weeks.
Well, thanks, Mia. It's a pleasure to be here. I know nothing about doing podcasts.
So it's a good balance then.
Yeah, fantastic. I'm looking forward to it.
Excellent. So it's a good opportunity to introduce our guest, Dr. Tony.
Thank you. It's good to be here.
Can you just explain your role briefly?
When the long-acting injectable buprenorphine became available, Nico asked me if I'd actually start work to help develop this clinic to meet the needs of the clients.
Can I take you back to that time when you came? It was soon after we'd opened, and I think you were the first person who put their hand up. What made you want to do that?
Well, I'd spent my professional life as an anaesthetist. I was Director of Anaesthetics at the Alfred for nearly 20 years. And during that time, I had no choice but to become aware that the problem anaesthetists have handling opioids. And it had been quite well reported in the United States that a significant proportion of anaesthetists, or percentage of anaesthetists, became addicted to opioids in their professional life. And it's not clear whether they chose the profession because it gave them access to opioids, or whether the access to opioids as part of their work made them at risk of becoming addicted. The tragic case at the Alfred of one of our trainees who became addicted to pethidine. He was treating bipolar disorder, and I'm not giving away any secrets. This was all public information, having been to the coroner. But he flattened out his manic phases and dealt with the pain of life by taking pethidine. And he had some time off work and came back to work, but tragically took his own life after he relapsed to using pethidine. That led me to study that in Australia and New Zealand. And I did a survey of all the anaesthetic departments of Australia and New Zealand. This was published back in, I think, 1998. And my estimate was that 1.8% of people who started anaesthetic training became addicted to opioids. Shortly after that was published, I was invited to a breakfast, invited by Jack Warhoft, and there were 12 other people sitting in the room. They were all past or present anaesthetic trainees who were addicted to opiates. So it wasn't 1.8%, and their departments hadn't known about it. So I was pretty confident it was more like 1 in 25 of people who started anaesthetic training became addicted. It was really from that I appreciated the difficulties of addiction. As I retired as an anaesthetist, I wanted something useful to do, and that's when North Richmond was getting bad press for MSIR starting to open, and I thought, well, I'd like to help if I could. So I had a conversation with Nico, and he invited me to sit in the injecting space itself to see what I could do to help the clients. And that was it was a mind-blowing experience. I don't think I've ever learnt so much in such a short time as getting to know the clients.
What do you mean by that?
My first impression was when I was behind the desk and the clients were coming, and I think the injecting room had only been open for about 3 or 4 weeks. But I was absolutely blown away at the politeness and respectfulness of the clients towards the staff. I think that the anxiety that people have about drug users wandering the streets in Richmond is so misplaced, because these people were really grateful for the help and were incredibly polite to the staff. And it's not as though the staff had had a long time to train the clients to behave in a particular way. They were genuinely grateful people, happy to have advice. I was sort of shocked when Nico asked me, would I help people who were having difficulty injecting? And that sort of seemed counterintuitive. But you described the distress that people get when they're in withdrawal and having trouble injecting, and the distress it caused to the staff and the other clients when they couldn't inject. As an anaesthetist, putting many needles in veins over a long period of time, I know not only the easy veins, but the deeper veins that people might need to use to find. And the clients were incredibly grateful for that. As soon as the long-acting injectable buprenorphine was available, that led the clients to ask me, saying, you've helped me inject, but I've had enough of injecting. I don't want to inject any more. Can I get onto this drug? And so it was a really important way of establishing trust between the clients and a doctor, and people who inject drugs do have such terrible trouble accessing healthcare for so many reasons.
That relationship that you built by helping them inject was then later facilitated them reaching out to you saying that they wanted some assistance helping come off the heroin.
They knew that I was a doctor who wasn't going to lecture them on not using heroin. I was a doctor who was prepared to help them manage their heroin use. It was a really good way of opening the door.
And just to clarify, you weren't injecting people, you were kind of offering advice to them on what might be.
Yeah, I was using my knowledge of anatomy and how to find a vein to show them or describe to them how to do it and just guide them as they were doing it.
It might be worth mentioning at this point that some of the less than ideal injecting practices that some people or had been using over many years that we witnessed in the injecting room.
Well, many of the people who inject drugs have damaged the superficial veins that are normally easily to see just under the skin, and so start injecting either into deeper veins in their neck or around their groin. And particularly around the groin causes trouble because they tended to inject in the skin fold and get chronic infection there. So there's chronic infection around the vein and also beside the artery, and that sometimes causes serious trouble for them. To teach them ways of doing things cleaner and safer than they had been is better for everybody.
You find yourself in the injecting room, and did that make you reflect on the experience you'd had earlier where the registrar had died? Because that clearly had affected you at the time.
The bigger impact of my hospital experience was to see how badly I and others working in hospitals deal with people who are addicted to opioids. The wait in emergency departments inevitably puts them into withdrawal, and then they're easily identified as drug seeking and they're likely to leave before they get treatment. So there are people who've got infected heart valves who've gone to hospital because they're sick, but they just can't wait for long enough. It's almost that their opiate substitution treatment needs to take place as first aid so that they can then access other health service. Or the pharmacotherapy, the opioid substitution, is usually delayed, and that's a real barrier to treatment. One of my early experiences of taking blood was from a guy who turned up fairly early one morning, and the staff indicated to me that he wanted blood taken to get tested for hepatitis. So I started chatting to him, and he was dividing up his heroin using his Melbourne Cricket Club members card and his platinum visa card. And he was telling me he'd never had to steal to get money for his heroin. He's always had good jobs and $200,000 a year for the last 10 years in construction. He'd been to a private school, and 13 years of private school, all he ended up with was the drug addiction. But he'd had a pathology request slip with him for 18 months. He'd been to 5 different pathology centres, and the person there would have 2 goes at taking blood and then say, well, I can't get blood from you, you'll have to go somewhere else. So he just carried this pathology slip around wanting to get tested for hepatitis C. And I was able to take blood from him by using one of the larger veins that probably only anaesthetists and radiologists know how to find. And it turned out that he was positive for hepatitis C, and he got treated. and we tested him again and he was cleared of Hep C. But without access to the injecting room, he wasn't going to get blood taken. It just wouldn't happen.
And we should say many people, in fact, die of hepatitis C in Australia more than who die from HIV now, either from liver failure or liver cancer.
Yeah, and I think that's one of the messages for the community that aren't certain that the injecting room's a good thing. The Sydney injecting room got public traction because people were worried about HIV and that it was going to get from the homosexual community through the drug injecting community, and everyone was at risk from that. So having an injecting room to slow that down was a good thing. Well, hepatitis C is the same thing today, but it doesn't have the public traction that HIV/AIDS did 20 years ago.
Well, that kind of brings us round to the topic of the day, which is kind of opiate pharmacotherapy, and how you came to be prescribing it in the medically supervised injecting room. Had you had any experience with that before?
Not really. And there were occasional patients in hospital who were on pharmacotherapy, but really very, very few. So I had virtually no experience until you encouraged me to start prescribing.
What was your initial reaction when I suggested that maybe that would be something that you might want to consider?
I'd have to confess my initial reaction was horror. But then when I thought about it, I think my reactions were coloured by my views of methadone and the difficulty of prescribing and needing for people to get new prescriptions because they'd missed a couple of days at the pharmacy. Whereas the injectable buprenorphine is really relatively such a safe preparation to give clients, and it's easy to help them to manage their opioid use. So many of the clients that I first met they'd been on methadone several times before. They'd been on buprenorphine sublingually daily doses, many of them had that, and they knew they couldn't cope with daily dosing, so they just wanted an injection to get some treatment into them to help get control of their heroin use.
Do you remember your initial experience with the pharmacotherapy?
I can think of a couple of early ones, and they were quite different. There was one I recall, and he'd been using heroin for years after having multiple trauma, as in a car accident, and had fractured his spine and both femurs and his pelvis. And he'd been on long-term opioids and heroin use, and he had been attending the injecting room quite regularly and decided he wanted to go on the buprenorphine. And he started off with a dose, and I think we were actually going to a meeting in town in the health department, and I saw him out the front, and he said, "Don't worry about me being here, Doc. I've just came to get my phone charged." And instead of using heroin 3 or 4 times a day, he was then working in the backyard growing veggies in return for board, and he was able to work in the garden and get back to doing his art. And I think I actually met him because I'd helped him inject when he was having difficulty. So there was another guy working in construction, and he just used a little bit of heroin before he went to work every day, and I thought a lot of people who worked into construction were drug tested, but it seems that they didn't pick him. And he actually just had a 1 weekly injection and then didn't use heroin for nearly 3 months. And that was enough to stop him. And it's very hard to understand pharmacologically how it kept him clear for that time, but still on treatment. He just comes back every so often and has a small dose and is very grateful for our care.
Maybe it's worth at this point mentioning a little bit about the different medications that are available for pharmacotherapy. You've mentioned methadone, which is it's an opioid which has been around this clinical use for probably about 50 years around the world. It's a long-acting opiate solution, which most people can take once a day. Some people find it wears off a little bit before that. But in the system we have in Victoria, you go to the chemist every day, unless your doctor thinks that it's suitable that you go less frequently. And there's a cost of typically about $5 a day, that like a pharmacy dispensing fee, which our clients have to take. And then maybe about 20 years ago, buprenorphine came onto the scene. Buprenorphine's another opioid, but it only partially stimulates receptors, so it's inherently a little bit safer, and some people prefer it, some people don't. But again, it more or less only lasts a day, sometimes 2 days. And so this new medication that you're talking about, Tony, that's a form that's relatively new. It's only been available in Australia for a couple of years, and we were fairly early adopters of that, is an injection that forms like a waxy ball under the skin when it comes into contact with water, and is slowly absorbed by the body over a week or a month or longer, depending on the formulation. So this is really the first time that kind of people have an option that if you take this injection, it's an opiate, you won't get withdrawal symptoms, and you don't have to go to a chemist every day to receive a dose. We should also add that depending on the dose, it also blocks the effects of heroin because it binds quite tightly to the opiate receptors. So if somebody was to use heroin, they may not feel anything. They might, depending on their views, they might be happy about that, or they might feel like they've wasted their money. And there was some anxiety in the drug and alcohol community when I proposed that we were going to offer this treatment at the injecting room, that we might be putting some people in a situation where they won't be able to cope with the kind of the way that they feel, because many of our patients have experienced significant trauma in their lives. And so it was really an experiment. We weren't really sure how it was going to work at all, but fairly quickly it became clear, as you're saying, Tony, that many people really had very positive experiences, and they were saying that it was the best treatment of their lives, and so on and so forth.
Yeah, and certainly I felt the anxiety amongst some clients and some of the staff too, as to were we possibly doing something terrible to these clients by depriving them of the ability to get the opioid effect. And I think that's a really valid concern, particularly when the reasons people start using opioids. They've had abuse as a child, they're part of the stolen generation, they've had all sorts of life traumas, they're treating their undertreated psychiatric illness, and the warm hug of heroin is what allows them to keep going. And there are certainly some people who find the effect of buprenorphine unpleasant, and they do need some more positive opioid agonist. But the vast majority of clients are incredibly grateful. I think for two reasons. One, it takes them away from a daily medication, and it saves them that daily decision of, will I take my pharmacotherapy today, or will I use heroin today? But you think of the difficulty people have giving up cigarettes, the daily decision to smoke or not smoke, the daily decision to use heroin or not use heroin, the daily decision to have pharmacotherapy. Well, having the injection that takes that decision away has been really helpful for so many people. And I think that's one of the reasons why the monthly injection is particularly good, because it gives people a bit longer to readjust their life. It's a bit like starting a new diet. You can do it for a week, but then you can lapse back into different food habits. But if you do it for longer, you can sustain it longer.
Yeah. When someone has trauma and you called it the warm hug of heroin and you take that away, in terms of having the trauma though, is obviously it won't go away. The trauma will still be there. Do you kind of offer other services to help address that issue that is contributing to the drug dependency?
Yes, certainly. There is counselling available, and we refer off to other services. We have a psychiatrist as part of our clinic, and he's very helpful dealing with those clients. And also sometimes the fact that they are without the opioid effect, it allows them the time and space to actually address what that trauma was in a constructive way, where they're not interrupting their ability to process it by keeping on using opioids. So there are some people who have that almost paradoxical response, whereby being really clear-headed, they can work through something that they hadn't previously been able to work through.
It might be worth talking about what that exactly looks like. I mean, maybe, Tony, you could walk us through what happens when somebody comes and says they want to stop using. What does that look like in the context of the clients in the injecting room?
If I can just go back one step further, I think it's important to recognise it's a two-edged sword, in that we need to make sure that we're making people who are going to continue to use heroin welcome in the injecting room. So we can't be preaching to people who don't want to hear us that you should go across to the clinic. But what we do is make the staff are very receptive to the clients who give an indication that they don't want to use heroin anymore, or that they do want help. The way the injecting room works, there's a reception space, an injecting space and an aftercare zone. And the aftercare zone is where the clients who, after they've used heroin, are able to sit around and engage with the staff and talk about the things that they need help with, whether it's housing or food or clothing or treatment. And the treatment we offer, all they need to do is mention that to a member of staff and they'll be walked through into the consulting area. Whoever's available will talk to them then about their options for treatment. And then the clinician simply needs to apply for a permit. Many of our clients already have permits at North Richmond Community Health Service, having been to the general practitioners here before. We need to get a permit, which can sometimes be done same day. And then as soon as the client's in withdrawal, they can start having the buprenorphine treatment. So it's a very fast service compared to somewhere where they need to make an appointment.
How long does it take somebody to go into withdrawal typically?
It varies enormously between the clients. Some people will not have significant withdrawal symptoms for 24 hours, and some will be really uncomfortable 4 to 6 hours after they've had a dose of heroin. And that's one of the things we need to work with them. It used to be said they must abstain from heroin for 24 hours. Well, for many of our clients, that simply isn't going to happen. So it's a matter of timing their heroin use and their attendance for their first dose of buprenorphine, so it causes the least discomfort.
So you apply for a permit, you tell them to come back when they're in withdrawal, they come back either later that day or the next day, and then what happens?
But as soon as they turn up in the consulting area, we check that they're in adequate withdrawal and administer a dose of really whatever preparation they'd like. And most of them want to go on an injection because most of the clients have had daily dosing before and know that doesn't work for them. Whether they choose to have a weekly injection or demand a monthly injection, it's up to them, and we'll just work with them.
And so that's provided on site? They don't have to go anywhere else for that?
No, it's all on site and without charge. And that's one of the real kickers for our clients who often don't have spare cash. So having to go, 1, make an appointment, 2, wait to be seen, and 3, pay money, all mitigate against them finding treatment anywhere else.
I'm here with someone who's an MSIR client and is very kindly offered to tell us about his experience using Long Acting Injectable Buprenorphine.
Hello, my name's Peter. When I was 14, I started using heroin. I'm 65 this year. I've been on Buvidal over 3 years, which has saved my life. I've now got a job, which is only 1 day or half a day a week with North Richmond Community Health, which is helping me greatly. The Buvidal, I get the injection 3.5 weeks. I find that if you go 4 weeks, it starts to run out real quick. I advise anyone that's on Buvidal, don't miss your appointments or your injections because it does run out quickly. Over the last 3 years, I've got 3 guitars, an amplifier, I've got a large, big 55-inch TV, the speakers either side are 5 feet high. I'm getting my life back together. I'm getting possessions, which aren't that big of a deal to me, but creature comforts always come in handy. And if I hadn't been on this Buvidal, I'd have nothing. I'd still be using the injecting room or in jail. And North Richmond Community Health, especially Dr Matt Penn, has helped me greatly. I see him weekly for my own state of mind, and we have a chat, but every 3.5 weeks I get the Buvidal shot.
So it's changed your life a lot for the better. Do you have any goals for the future?
Like, I'm a professional artist. I've got a MA in Fine Arts, and I'm a potter by trade. And we're looking into setting a pottery up in the future, and also with people in the injecting room, an art space for them where they can paint or do some pottery but this is going to take time to get up and running.
Well, you started when you were a teenager and now you're in your 60s and you've quit. That's amazing. Well done.
Thanks. I'm just starting to be proud of myself because it's taken time. Slowly as it goes, things will get better.
So for anyone considering, it's called Long Acting Injectable Buprenorphine. The brand is called Buvidor that you've taken. What would you have to say to someone considering taking that?
I'd say to them, get it into you as quick as you can.
And what about the transition from taking heroin and feeling those effects, the euphoria and whatnot, and then having that taken away? How did you manage that?
I haven't felt the euphoria from heroin for 40 years. It was just a lifestyle. And when I didn't have it, I got sick. When I had it, I wasn't sick. When I have the Buvidor, I don't have to worry about heroin. I don't have to worry about anything except my next injection of Buvidor.
Well, that's a good point, because when you are taking heroin just to get by, not to get high at that point. Is that right? People might not know that.
Yeah, exactly. I didn't get high off the heroin at all. I haven't got high off heroin since my 20s, I think. And the heroin I was using was very, very good grade of heroin. It wasn't street heroin. It just doesn't work after a while because the receptors in your brain get that used to it. You need more and more and more and more and more. And when you need more and more and more, you've got the chance of ODing or... And it's been over 3 years. I've been straight, which is great. Doors are opening up for me, which I never thought would happen. But I'm working towards these things. I have known people to use on top of the Buvidor that feel nothing. And that's the aim of it. And it works. And it's done wonders for me. It could do wonders for a lot of other people that have addiction problems, especially with heroin or opiates.
Back in the studio with Dr. Tony and Dr. Nico.
Another aspect of this medication, at least now, it's recommended that you can initiate people with the injection. In the beginning, there was less experience with that, and the manufacturer was recommending that you stabilise on a daily dose of the sublingual buprenorphine first. Sublingual is the form of buprenorphine that's been around in Australia for 20 years that you put under your tongue and you go to the chemist and get every day. So that was our... there's the methadone that you drink and then the buprenorphine that you put under the tongue. They were the two medications that were available. It was considered easier to transfer somebody from one form of buprenorphine to the injection rather than from heroin directly into the injection. You mentioned that some of our clients didn't want daily dosing. Does that mean that they weren't keen on stabilising on the sublingual buprenorphine first? And how did you handle that situation?
Well, many of them just downright refused, and they'd say, "Doc, if I could take daily dosing, I'd be on it." So they were very clear about it. I discussed with them their options, and many decided that they'd much rather just have an injection, recognising that one of the values of having dissolving wafer under the tongue for a few days is that you have a better idea of how much heroin someone's using or how much buprenorphine they need to stay out of withdrawal. The beauty of being in the injecting room is that we see our clients come through quite often, or many of them were coming in a few times a day, and we know how much heroin they were using. So it was very easy to know about how much buprenorphine they were going to need. So we tended to give a slightly conservative dose that we expected to meet their needs, but always said that if it wasn't enough, come back and we could give them some more. But as soon as they felt the drug effect was waning, they'd come back and get a top-up dose.
So what you're saying then is really within the safety parameters, flexibility was really the core of the way that the treatment was offered to our clients.
Yeah, I remember sort of being taught about methadone and people doing drug testing and the clients had to abstain. And, well, I mean, if someone uses heroin on top of their methadone, surely that means you just give them more methadone, not that they should be punished or dropped off the methadone program because they were using. And I think there's a sort of a medical model of pharmacotherapy where the doctor tries to be in control of the client, whereas we have much more of a harm reduction approach to pharmacotherapy where we're providing the drug to help the client manage their heroin use. And if they want to stop completely, fine, we're happy to help support them do that. But if they want to have pharmacotherapy and are going to use heroin less than they were, then that's a much better outcome for the client and much safer for the client. We shouldn't be offended or feel diminished or frustrated that the client hasn't stopped using heroin altogether. I mean, how many people chew nicotine gum and smoke a cigarette too?
Yeah.
That's okay. Less cigarettes is better. Less heroin is safer. And many of the clients develop a pattern of doing that and then gradually choose to stop using heroin.
And that's in fact a principle of engaging with people who've had traumatic life experiences. The kind of a trauma-informed care is increasingly been shown to be an effective way of helping people like our clients receive various different forms of interventions. I can say that at that time you were the main opiate prescriber in our clinic. I personally aware of many clients who kind of really appreciated their kind of refreshing approach. Did you get much feedback from our clients in that way, that the treatment that they were experiencing with you had been different to their experiences in the past?
It was incredibly rewarding. And I had one just the other day thank me at the second consultation for being so willing to work with him to manage his heroin use. And I think it was probably easier for me because as an anaesthetist with a knowledge of the pharmacology, particularly of buprenorphine, I knew what could be administered safely. I think so much of methadone prescribing has been tarnished by anxiety for the prescriber that if their client or patient comes to harm while they're on methadone, that the doctor's done something wrong. The practice of needing to be re-prescribed or the dose reduced when people miss doses. I mean, when people stop using methadone for 4 days, that's probably because they've used a lot of heroin in that 4 days. It's not that they haven't had any methadone, it's they've used lots of heroin. It sort of became a punitive approach to prescribing methadone rather than dishing it out, withholding it. And I think as an anaesthetist, understanding the safety of buprenorphine relative to not having buprenorphine made it much easier for me to be flexible and to provide the clients what they wanted. And I think you've mentioned the hepatitis C treatment and the difficulty of our clients who have had trauma. The notion I've enjoyed describing the injecting room as a Trojan horse in getting health care to the clients who inject drugs. And our clients have so much trouble getting health services elsewhere. The clients who we used to diagnose on the basis of their blood test, would have to go and see the gastroenterologist or the GP and have other tests and then have a prescription. Whereas with support from the team at St V's, we have on-site finger prick tests. So people come in to use heroin, and if they haven't had a hepatitis C test recently, they can have a finger prick. By the time they're ready to go, they'll have a result which may be positive, and if it's positive, we'll send them away with tablets. They've simply come in to inject heroin and they've had their hepatitis C diagnosed and treatment started on the same day. And for those that are homeless and can't look after the tablets, they get their hepatitis C treatment when they come in to inject heroin. So it's providing healthcare to people who just otherwise wouldn't get it.
I think you described it in your own words as like a cameo at the end of your very successful, happy career as an anaesthetist. You've done something completely different that you never imagined that you would do, and you found yourself being an opiate pharmacotherapy prescriber. How would you reflect on that experience now?
I might tear up at this. I think it's probably been the most rewarding 3 years of my professional life. I got to do great stuff as an anaesthetist, anaesthetics for heart transplants and lung transplants and neurosurgery and all sorts of things. But to meet and get to know this client group and have them share their stories has been just an incredible privilege. Yeah, I've often said to people, the male pale and stale at the golf course who just want to lock up all drug users, getting to know this client group and be able to help them, but also to have the reward of them being so outwardly appreciative. You get much more I've had much more thanks from this group than people I've anaesthetised for major surgery. They are much more grateful for such a small thing that doesn't take a great deal of time or effort. It's just a matter of being there. For our clients, that's such a rare thing to be able to access healthcare without stigma attached.
Yeah.
And I think for me, it's been a real privilege.
Why does it appear more effective for some people, the LAIB treatment?
I think many of our clients have got a shortened time horizon, that rather than planning what they're going to be doing in 5 years' time, they're kind of thinking how they're going to get through the day. But, part of that is thinking, when am I going to next have enough money to get some heroin, because that's been the pattern of kind of coping over many years, for example. And that often extends to over the next 24 hours, maybe over the next week. But doesn't really think, I'm going to book my dealer in 3.5 weeks' time. And that just takes it away from now. You say, you can't use now. I don't need to use now. When I feel like it, I'll deal with it then. And then many people, it's far enough away that it's out of now. And then it wears off so gradually. Some people that don't even notice that it's worn off. And like you were saying before, people come back and maybe 3 months later they've started using heroin again. Oh, I forgot to get that injection, and they come back and they'll get the injection. So I think the capacity for it to provide a sustained effect over a long period of time really does help people take control over their own substance use.
How do you project this new treatment to go over the next 5 or 10 years? Do you think other people, similar clinics around the world, will open up and start delivering this kind of treatment?
I think it's certainly the so we've done some research with our clients as to what they think about it, and we've done some analysis of how often they use the injecting room before and after starting treatment. And together with Tony, we've looked at that, and we've seen really there's been a dramatic reduction in the number of times people use the injecting room, and a dramatic reduction in their self-reported heroin use. It's by far the preferable treatment compared to treatments that they've had in the past, and it's the main thing. It's the main option that people ask from us when they want treatment. Often people will come in and say, my mate's had this buprenorphine injection, and they say it's fantastic, where can I get it, kind of thing. All new treatments have a kind of new factor, but in my experience in providing this kind of treatment for 25 years now, it's the first time that you have so many people come and say, really, this has really made a big difference for me. It's the first time in my life I've been able to do what I want to do. And so I think that it really is a game changer for treatment of heroin dependence. We get a lot of interest from people around the world who are wanting to look at our experience with this medication. And this was perhaps the last group that people were thinking to target with this medication, but I think it's really a group who really like it, because the kind of the alternative of going to the chemist every day, paying $5 every day and getting regular appointments with the health services, that hasn't worked for them. And so it is going to be used increasingly around the world with this population.
And you're one of the first people to take it up?
Yeah, I think we really have a unique experience, and I think, if we have the time, we do get requests to share our experience. Tony, thank you very much for sharing your experience today. I think it really has been a privilege to work with you in the time that you've been here, and thank you very much for sharing your story today.
Thank you. I'm happy to share the story, and I think this is a great treatment for heroin users. But the challenge for the community now is to reduce the things that initiate heroin use, so reduce those traumas, have proper psychiatric services so people who need psychiatric help don't need to go to heroin because they can't get psychiatric help. To deal with the traumas, deal with the inadequate housing, deal with family stresses, do those things more constructively, and hopefully prevent so many more people from starting on heroin.
What's your comment to listeners listening today when we've been discussing LAIB, and some people might be considering, perhaps they're the director of a medical clinic similar to yours, perhaps they're someone who uses. What would you have to say to the listeners?
Look, I think, as we've heard from Tony, this is both a medication which can be used in a way to help people gain control over their heroin use, which is both really rewarding for the people using heroin and rewarding for the prescriber, the doctor, the nurse practitioner, because we definitely need more doctors and nurse practitioners to work in this field, because there's really a shortage of those, and in Victoria in particular, most of the people prescribing pharmacotherapy are an ageing group who are kind of have hundreds of clients, and as they retire, we're really going to struggle unless we can kind of share the work around. And it's such a nice treatment to use that I'd really encourage people to take that up.
Thanks Dr. Nico and Dr. Tony for taking us through how they use long-acting injectable buprenorphine as they work with the client to manage substance use, along with other components of trauma-informed care. Thank you also to Peter, being generous with his time and sharing his experience with the OAT treatment. If you want to find more information about the clinic, the website is nrch.com.au. As always, it's been lovely to be with you today. Thanks for listening and take care.